decisions would be fixed stats in the drinking water or aspirin for all. So those are the next two examples, one of which is KIF6, stands for kinesin protein number 6. There's a very rich literature in the chemistry population on kinesins. They're intracellular transport proteins. Those helical two proteins wound around attaching to the cargo are supposed to be or represent kinesin 6. They walk along microtubules. They drag cargoes from one side of your cell to the other. This polymorphism is right at the tail where it connects to the cargo. So in terms of the amino acid sequence and molecular structure and the ATPase domains, all that stuff is very well worked out. And the amino acid shift and polymorphism is well worked out. Very recently, at the ATBB meetings in San Francisco a couple months ago, this mouse study was reported showing that KIF6 is highly localized to the area of plaque rupture. So the concept here is whether or not any test predicts anatomic disease, like perhaps 9p21, or does a genetic test predict clinical events that might not have much to do with anatomic disease, but with plaque rupture. So those are two different concepts, and now I'm talking about the concept of clinical events, perhaps related to plaque rupture. So this data is derived from over 50,000 research subjects, 4 prospective statin trials, hair loss, phosphorus, TB22, and then 3 cohort studies, ERIC, CHS, and WHS. So that's where the data comes from. A really interesting thing about this is that KIF6 is present in about 55% of the population, and if you have this polymorphism, your risk is moderately higher, but if you take a statin, that eliminates the risk. So here's data from west of Scotland. The top line represents the placebo group that were KIF6 carriers, and their risk ratio was significantly higher, terrific. The second line down there are people that are KIF6 carriers that were randomized to pravastatin, and they don't have any risk because they've got the treatment for KIF6. Take those top 2 lines, add them together, that's the third line, so half of them are on statin, half aren't, they're all KIF6 carriers. This would not have been statistically significant if half the population were on statins. The reason that's important is because Bob reported the Ottawa Heart Study and said that there's no association of KIF6 with angiographically defined coronary disease based on my study in the Ottawa Heart Study. If you go back and look at that, though, 89% of the people were on statins because they were derived from a coronary cath lab scenario. So this is true of hypertension or anything else. If you wanted to find hypertension genes, and a large proportion of the population were on antihypertensives already, you'd never find a gene. So just remember that when we talk about large association studies. So in terms of treatment, these are double-blind randomized placebo-controlled trials. And the absolute risk reduction of the white bar was what was reported in the original New England Medicine of article manuscript, 3.5% reduction in care. The KIF6 carriers on pravastatin, 4.9%. The KIF6 non-carriers on pravastatin, exactly the same LDL reduction, 1.4%. Reproduced in wascops, 3.5%, the original New England Journal article. KIF6 carriers on statin, 5.5% reduction. Non-carriers on statin, identical LDL lowering, 0.1% reduction in events. So this was shocking to me as a lipid guy when this first came out. So in today's meeting, we have a quote that I put in: find the people who need the treatment the most. And this test certainly finds the people that derive most treatment from statins. So to summarize quickly in this, over on the left in the red are the KIF6 carriers in care wascops prosper improve 22, receiving the drug, getting about twice the absolute risk reduction as reported in the original paper. The non-carriers on the right also got the exact same drugs, the exact same lipid change, the exact same CRP change in the case of TB22, and very little benefit from the drug. So in TB22, on the left are the pravastatin carriers, or carriers given pravastatin in blue, given atorvastatin in red, LDLs of about 100, pravastatin about 70 with atorvastatin, showing that if you're a KIF6 carrier, you derive significant benefit from taking 80 of atorva compared to 40 of prava. On the right are the non-carriers who are also randomized to pravastatin and atorvastatin, no benefit whatsoever of going to 80 of atorva and getting the LDL to 70 compared to 100. We saw, oops, sorry, I'm hitting the wrong button here. The thing that amazes me about TB22, though, is time to benefit. On the left is what you saw in the original paper, showing that at 180 days, there's a significant reduction in clinical events. attributed to atorva versus 40-preva. On the right is the genetic sub-study showing significant benefit at 30 days if you're a carrier, not 180 days. So what this says to me is that the benefit can't be because the plaque is getting smaller. It can't be because your reverse cholesterol transport is better. It has to have something to do with plaque stability and plaque instability, and it's localized right at that area where the plaque ruptures. So here's the thing that's really getting a lot of interest. This is the numbers needed to treat. In CARE, if you're a non-carrier, an NNT was 72. If you're a carrier, it's 20. Down at the bottom, with Prove It to Me 22, to get benefit from atorva, if you're a non-carrier, is 125. If you're a carrier, it's 10. So in carriers, this is a really smart, efficient thing to do. In a non-carriers, it doesn't make much sense at all.
Can we stop here for a second?
Sure.
Can I
I mean, this is groundbreaking. So 28 days or 30 days is not enough to stabilize the plaque, in my understanding of pathology. Now, the pathologist is sitting here. Could it be because of changing the equation in the vulnerable blood component? Any study has linked this to anything in coagulability and chromogenicity?
Oh, in terms of like plasminogen or pipeline or
Yeah,
something?
because that's so fast. That's not enough to change plaque dynamic.
But there are event reductions with statins that are that fast. No,
Could be because
we don't know what the benefit is, but Armida ACS used a Torva 120 and showed 7-day benefit. 7 days.
PCI, because immediately down. Subjected high dose statins immediately at PCI is reducing.
Right.
Well, there are some studies saying those are because of the inflammatory effect on the reperfusion injury that is associated. It's just not really anything with plaque. It's just myocardial. So we have myocardial, vulnerable myocardium affected, here vulnerable blood affected. Erling, plaque, can we stabilize in 30 days? 30 days?
Yeah, endothelial function improves in 72 hours after a statin.
Yeah, endothelial function, yes.
I think it's after a big.
Okay. I don't know, we're getting into dark side, but I'm just saying this is, CJ, you're going to erase the question?
No, I'm not going to erase the question. Perhaps this may help inform a cogent answer to your question. In Prove It, 75% of the treatment benefit on a 5-endpoint composite endpoint. In Prove It, 75% of the statin benefit on a 5-component composite endpoint was driven by revascularization. And so the question I have for Dr. Superka is that, is this gene somehow modulating plaque characteristics? Or I've always thought the need for revascularization was a subjective endpoint driven by local practice patterns. So I'm not quite sure there's much to be made here, but I'm very intrigued by the possibility that if a marker like this could help discriminate responders from non-responders, I think that would be worthwhile. Maybe this ought to be looked into, because I'm not quite sure about CARE, WASCOPS, and PROSPER, what drove their endpoint, the primary endpoint. But in Prove It, 75% was driven by revascularization.
CARE was definitely hard endpoints only.
Yeah.
Prosper and WASCOPS were not only hard endpoints, but CARE was absolutely hard endpoint trial, with secondary prevention, driven by MI and death only. So that one as a standalone is clear. The other ones follow along, but it's definitely food for thought.
Yeah, but one to
But how can you explain that it is working for pravastatin but not for atorvastatin? How can you understand that it's only for one?
Is that? No, it's...
Yes, no, you
Can you go back to that slide?
The Wolfing study is comparing pravastatin to atorvastatin.
Sure, yeah.
And it's there was this
That's
difference.
what my understanding was, too. It only works for Prevacid.
So the first studies were Prevacid studies. Prove It's the only study that we have the 2 different drugs in. And in this case, with the carriers, atorvastatin is superior to Prevacid. Whether or not it's because the LDLs got to 70 or whether or not it's different characteristics in the statins, we don't know. We'll have a little bit more data with Jupiter in a little while, but we don't have studies where they've compared what it
But
stands
when you
for.
look to the curves directly, it seems to me it is the effect that you are diminishing the effect of atorvastatin, despite the fact that you are improving pravastatin. If you look to the curve, after 12 months, it's nearly reaching 20% as on the other side.
It would be interesting to
But-
superimpose
but-
them.
Yeah, and
Oh.
but you see that atorvastatin is increasing. The number of events is increasing.
But it's regression to the mean, right? They're coming together in the middle, right, which is very interesting. They're coming together, the two curves
The two on the
are
right.
merging together in the middle between the two different event
Yeah,
rates.
it's not the effect of one drug alone, it's the other part, it's the other way around.
Mhm.
Hey, can you look at the
Hard endpoint data for this, I mean, it can easily be done. If you eliminate the soft endpoints, improve it, and see what mortality or MI is being impacted or stroke is being
But
impacted.
Sanjay, I don't think that should be done if he's saying it does affect plaque stability, because revascularization is done, I'm not saying it's done properly, but it's done because plaque causes noises, plaque becomes unstable, causes clot, and it becomes something that they want to do something with it.
Well, the only thing is because I am a little bit,
Reluctant to accept need for revascularization.
No,
It's
I'm not-
purely a biologically driven
No,
intervention.
forget about whether they're doing it right or not, but it is something that is driven by plaque instability.
Possibly.
Well, that is what is happening because plaque changes. Somehow, on angiogram, plaque changes, and that changes in plaque is resulted from either from plaque instability or from blood that causes clot and seeds the plaque. But I don't think removing that, it's good for your statistical hardcore analysis and endpoint and cost effectiveness, but really plaque instability, if they can find the link, what they showed in mouse, consistent in human, that's a serious finding.
No, it's hard
it's hard for me to understand.
how a plaque can, a destabilized plaque with, let's say, a non-obstructive lesion, nonetheless destabilized, can drive revascularization. This is essentially a flow-limiting, stenosis-derived symptom
No,
driven.
it can't. It causes locus thrombus. Locus thrombus changes hemodynamic. Patient comes with some symptoms. Then they go and put a catheter. They're trying to open it up.
But if it's not flow-limiting, why would you want to revascularize?
They do become flow limiting. They do become flow limiting, and they cycle, as you know, with this fibrinolysis.
I share the concerns that I think this needs to be replicated and it needs to have these events rather than the softer ones.
So the first three studies were hard clinical events in primary and stable secondary prevention patients. This is different because they came in as ACS patients to begin with. So they're two basically different patient sets.
But in this data set that you're showing, that's still a huge number.
And takes the other one, you see the shift of atorvastatin is to the left side, next one.
Or maybe it just took some time.
You see the red one are the carriers from go to the left side.
Mm.
I'm sorry, wait, say it again.
Yeah, you see that the high dose atorvastatin is better. The carriers are going to the left side. So it's significantly when you look at it up. And particularly in 30 days and then after, even after the end of the follow-up. Worse.
So not all the answers are in, that's clear. So should we keep
Is this
moving?
something, yeah, Celero's product? Is this a?
Well, the KIF6 is, but the Prove It To Me 22 is.
No, the KIF6 is something that's.
Yes, KIF6 was discovered through John Kane and Mary Malloy in an initial cath lab study and then replicated in all these other studies.
Robert, does this mean if you have coronary disease and you're KIF6 negative, you're screwed?
Does this mean if you have coronary disease and you're KIF6 negative, you're screwed? No, I think the way we're thinking about this now is chronic atherosclerosis accumulation versus unstable plaques and clinical events. So the classic model of LDL and low HDL leading to chronic atherosclerosis buildup, we still think is valid, but there's tons of people with atherosclerosis that don't have events. So this is, 1921 is sort of pushed towards that, it identifies those people. This, along with some other things, identifies people with, quote, plaque instability, unquote.
Now, I began ordering KIP6 on Berkeley Labs.
How much is it?
You know?
I don't know, but I found
I
one
heard-
zygote so far.
I heard through Axertic or, Jim, do you have an idea, Jim Erling? He's not here.
Well,
I heard like $200.
if somebody has to pay cash for it, it's about $100, but Medicare is paying for it and other.
Oh, is it
insurance.
paying for it?
Yeah.
Medicare is paying?
Yeah.
Okay,
But I'm not here to talk about the money part, I'm just here to talk about the science.
Robert, where
Yes.
is it located?
In KIF 6,
Yeah.
in which chromosome?
Yeah.
6.
Okay.
Robert, what does the mutation do?
It shifts, it's an amino acid shift at the tail end of the helical protein, and so we believe that it can't attach the cargo like it normally should.
Have you shown that, or is that hypothesis?
We've shown where KIF6 is localized. We don't know what the cargo is, but we know from in vitro chemical studies that it doesn't bind a number of potential cargos. But they're all in vitro type things.
Okay, so there are studies going on in the pathway in.
Oh yeah, there's a lot of studies going on, yeah. And there are other clinical trials that we're going to be analyzing. Okay, so I'm sorry, we'll move rapidly. That's sort of the. Okay, so this has to do with aspirin. LP capital A is a single amino acid shift polymorphism in the protease region of LP little a that was discovered through the Women's Health Study. And remember, Women's Health was 100 milligrams of aspirin every other day, 10 years of follow-up. If you have this polymorphism, the solid blue line, then your cardiovascular risk increases. And this is one thing that's been replicated ad nauseum as well. So there's no doubt at all that LP capital A polymorphism is associated with cardiovascular risk. That's well established. On this slide, you also see two red lines, solid and dotted. Those are the LP capital A non-carriers on placebo or aspirin, no effect. There's the dotted blue line. Those are their heterozygotes, LP capital A, randomized to aspirin, totally eliminated cardiovascular risk associated with this. The interesting thing about this polymorphism, unlike the others, is that it's only present in about 4% of the population. This was replicated in ERIC and men. I just won't show you that. The ERIC data was not randomized to aspirin. It was questions, do you take aspirin, yes or no? But this becomes important for the 96% that don't have it because of the issue of aspirin and GI bleeding. So there are lots of studies like this looking at 95,000 individuals saying there's a risk of GI bleeding when you take aspirin compared to cardiovascular benefit. So all the squares and circles to the left are primary prevention aspirin studies showing that there's about a 1-to-1 balance. For every cardiovascular event you prevent, you cause one GI bleed defined by hospitalization, blood transfusion, or death. So they're serious things. To the right is the Swedish angina study. Those people obviously have coronary disease. Cardiovascular events prevented is much higher, so clearly in secondary prevention there's no need for this. You give them aspirin. It's primary prevention that we're talking about. When you look at numbers needed to treat from Women's Health, if you're a carrier, the number needed to treat to prevent a cardiovascular event with aspirin is 37. If you're a non-carrier, it's 625. Take those numbers, and it turns out that there's about a 15-fold increased risk for GI bleeds compared to every cardiovascular event prevented. So the interesting thing with this polymorphism is to answer the question of should you use aspirin in a primary prevention population to prevent a cardiovascular event. So my question for this group is if that is then adopted in the community for that purpose, and there's a large adoption by the GI community, believe it or not, if you have a positive PAC score, does that roll you into the secondary prevention group or not? And so there might be a role to play for that here as well. So those are the key points of that. I'm going to save time and keep moving. Special populations. The firefighter study was a federal study we completed a year or so ago, reported at AHA and ACC. Firefighters have about 300% more heart disease than other people. We did the Illumina platform. We have 1 million SNPs in these guys. The information is starting to come out, but they're extraordinarily high risk. We did CACs, we did IMTs, we did ABIs, we did all this kind of stuff, and they have a ton of disease. So the main point for this group is within the SHAPE-2 guidelines, should you address special real high risk groups that could benefit even more from the types of screenings we've been talking about here, and we could have a whole meeting on that. So possible uses in the future might be earlier age of screening. So if you're 9P21 positive, should you have some kind of non-invasive imaging earlier? Should you screen family members? We have a family heart disease study ongoing in Atlanta right now, and you saw all the early stuff in the slides about family history questions. And is there enhanced compliance to medications? And we have a Medco study going on now. So here's a potential algorithm for primary prevention. They're high risk by normal standards over on your left. They agree to be imaged, and the physician agrees, then image them, don't do any further tests. If the patient or physician question the need for imaging, then genetic screening might be useful. Identify higher risk, that convinces people to get screened. No higher risk, one, lifestyle management. And over on the right, if there's no high risk by standard risk factors, then you do a screen, and if they're high risk by the genetic test, then you go on to non-invasive imaging. So that's just a quick little thing I threw together. Those are all the collaborators, just to be fair. All kinds of people were involved in the data that I just showed you. You know all these people here. The very last slide is this one. Bob Roberts came up with the idea of having a multiplex SNP panel, which was investigated about 14 SNPs. We're now looking at one that has 39 SNPs, and by eliminating certain SNPs within all these population bases we have here, we think we can come up with something that has maybe 15 to 20 SNPs on it that would be maybe $150, $200, and could be customized for age, gender, ethnicity, that sort of stuff, and very powerfully, much more so than 1921, identify high-risk groups. Looking at that, something like that within the MESA study in classification of non-invasive imaging populations would be really useful. This can potentially be relatively low cost because of what's going on in the industry, and hopefully be cost effective. So that's it, thanks.
Bob, one question. Is the LPA polymorphism is totally independent of the Lp(a) level?
Yeah, great question. The answer is no, it's not. So if you're a heterozygote or homozygote, the Lp(a) phenotype plasma level increases, but there's a bunch of people that don't have this polymorphism at all and have very high Lp(a) levels. So while there's a statistical relationship, you would make a mistake about 40% of the time if you assumed that people without this polymorphism did not have high Lp(a).
So the direction is to put 4 or 5 of these that you've shown and several that we haven't seen all in one plate, including KIF.
Oh, yeah. So the question is, do you want a chip that predicts risk, or do you want a chip that predicts therapy? And maybe we should have a chip that has everything.
Everything on it.
And it'd be $150 or something.
That makes a lot of sense.
Can I ask one last question? The pharmacogenetic testing for warfarin response to C9 and the VCOR C1, you would agree is probably the most mature for clinical decision making. What is the impact? What has been the impact? Has there been any traction in the community?
So we work with Alan Wu of UCSF on this, and he runs the clinical labs there. He's a very strong advocate. He's getting KIF6 up and running as well. And of course, the FDA came out with a warning statement about Coumadin and cytochrome P450s. Very powerful statements that this is important. Doctors, you should test for it. The insurance companies have decided not to test for it. 2C19 is very similar. Eric Topol's all over this. You know, he says everyone in the world should get 2C19 testing. The data looks really strong, but the major insurance companies have said, well, you know, we just arbitrarily decide we're not going to pay for it. So that's why you either have to keep the cost really low so that people can just pay for that out of their pocket, or somehow politically we have to get to the insurance company. Interestingly enough, Medicare pays for a bunch of this stuff.
Thank you. So we're moving now to the last presentation on this non-structural, non-invasive measurement, and Stephen Rosenberg is representing CardioDX. As I mentioned, CardioDX generously contributed to this meeting. Stephen is not the Junior's donor, he's a scientific officer. And so he's going to share with us the study results of the company.
So I just wanted to thank the organizers for letting us contribute, I guess is the right thing to say. So CardioDX is a molecular diagnostics company. venture back. We also just signed a strategic relationship with GE Healthcare. And their thinking, I think, is that molecular approaches may be complementary to imaging. And we agree with it. So what I'm going to tell you about today is the approach we took in the development and then the clinical validation of a gene expression-based test to ask the question, if a patient presents either in primary care or to a cardiologist with symptoms suggestive of obstructive coronary disease, this is not events, this is what's going on with the patient today. We wanted to develop a test that would enhance the ability to rule out the large majority of patients who really, at first-time presentation, don't have coronary disease. And also, of course, that requires a test with a reasonably high negative predictive value, so you don't miss people. And I'll try and take you through how we did it, what the approach was. This is gene expression, not genetics, and probably something some of you haven't seen before, so bear with me. So the challenges in assessing the current likelihood of coronary disease, especially obstructive coronary disease, is that there's lots of variation in the way clinical practice is done today, dependent upon the availability of methodologies, and also different patients present differently, especially with respect to gender. So that the combination of these factors leads to results that were reported by Patel in the New England Journal earlier this year, where they showed, and I think other people have shown this slide, that for those patients who were clinically indicated for having invasive angiography, less than half, in fact, had obstructive disease, and 40% of them had essentially no or minimal disease. And that even this was in spite of the fact that almost all of them, 85%, had non-invasive diagnostic tests. So just a brief primer on gene expression versus genetics. I apologize in advance for those of you who already know this. Gene expression really is looking at mRNA levels, can integrate genetics and environment for a patient. Will be susceptible to effects of diet, drugs, etc. It's time dependent, so it enables you, unlike your DNA sequence, to monitor potentially disease expression. As Robert mentioned in the last talk, unlike DNA, gene expression yields continuous variables rather than discrete variables. That gives you more statistical power. The advantage of this having a dynamic marker is both a blessing and a curse, because it has more methodological and sampling challenges, and we've spent a lot of time working on that. And this is an approach which has been used in other areas in medicine, besides cardiovascular disease, specifically in oncology, looking at breast cancer recurrence with the Oncotype DX test, and also in heart transplant rejection monitoring with the LMAT test. In particularly looking at circulating blood cells, you're really looking at a window on the immune response. And this focuses back on work that's been done by some people here and elsewhere around the notion that atherosclerosis, of course, has an inflammatory component. It's easy to get peripheral blood, but it's a very complex mixture of cell types, lineages, etc. In order to get the blood and get the RNA stabilized, you need to use some special techniques. And what you're really looking at here is the echo of what's going on in the vessel wall, and in our case, in the plaque, by the reflection of the response of those circulating cells to the presence of plaque. And that was really the hypothesis that we started with, to say, is there a change in the gene expression patterns of circulating white cells that will be reflective of the presence of coronary artery disease? And to take this through the process requires about as much diligence as it does to take a drug through. You really need to discover the molecules. In our case, that means discovering the genes and the messenger RNA levels that are sensitive. You need to develop the right methodology. Then you need to take those observations, which you can start from a whole genome approach, and narrow it down to a single algorithm or a single molecule you would then test, and then ask in a prospective study in an independent patient population, does the algorithm in fact add to the knowledge and had an appropriate standard endpoint, a gold standard endpoint to do so. So here's the hypothesis. I mentioned this already, the presence of significant coronary disease would alter gene expression patterns. We started off this work about 5 years ago now with 2 single center cohorts that were retrospective where the appropriate samples had been obtained. These were both cath lab cohorts, one from Duke, the so-called CathGen registry, and another from Eberhard Grubit in Seeberg, Germany. And in work that was published 2 years ago now, we presented a set of genes whose expression was proportional to the amount of coronary disease as defined by angiography, invasive angiography. We then went on, based on those results, to set up a prospective multi-center trial called PREDICT. Now it's over 4,000 patients, but there were about 1,800 patients and non-diabetics who were enrolled at this point. All of these patients were clinically indicated for angiography, and blood samples were obtained prior to the angiograms. 39 US centers, Eric Topol at Scripps was a PI, Alexander Lansky at CRF did QCA on all the angiograms. And the study design is really very simple. Clinic visit, first time presentation, no known coronary disease for these patients. And this is not acute high-risk angina or suspected MIs. These are stable patients. They may or may not have had non-invasive testing. Patients are screened, enrolled. We obtained about 200 fields of clinical data. A research blood sample is then obtained, and then a patient comes on and has their invasive angiogram. Those are then sent to the core lab for QCA, and we extract the RNA and quantify it at CardioDX. One of the observations in PREDICT was, in fact, mirrored by what was seen in the New England Journal article, which is if you looked at the extent of obstructive coronary disease, and that's either 50% by QCA or 70% by the clinical read. This is on the left-hand side of the slide. What you see is that there's quite big gender discrepancy. About 45% of men, but only about 20% of women actually have obstructive disease. Remember, these are all already referred for angiography. The reciprocal is also true. That is, men have less presentation with no disease, whereas women, in this case, minimal disease. Almost 2/3 of the women who went for angiography did not have any significant or no disease more than 35%. So
They don't have obstructive disease.
Correct.
It's not, they might have lots of plaques and.
Well, the vast majority of them had very little disease by angiography, like barely
I
detectable.
mean, these are luminography. We don't know what's going on in the wall.
Sure, absolutely. We're not talking about external remodeling here. You're absolutely right. So the process with the PREDICT samples is outlined here. I'm not going to take you all the statistics. Just to say, we started off looking at whole genome microarrays. We were looking at 20 or 30,000 genes and their mRNA levels, and ask, are there differences between cases and controls? Cases defined as greater than 50% stenosis, controls as less. The largest effects on gene expression were age, the proportion of cell types, and diabetic status. Because of the diabetic effect, which was actually quite unexpected, we subsequently limited ourselves to non-diabetic patients for the development of this first test. We derived some sex-specific age dependencies of coronary disease risk. A lot of people have shown slides which look like that already at this meeting, and I'll show you another one. We took in from our 20,000 or so genes, we narrowed it down to 113. These were then measured using a much more reproducible and sensitive method by RT-PCR in an independent cohort of patients. We then used a number of statistical approaches. I think the key points here are that gene expression tends to be highly correlated, in part a reflection of the fact that different cell types in blood have very specific, cell type specific gene expression patterns. In addition, the disease also causes correlated sets of genes to move either up or down. This gives you a much more robust signal than looking at single genes. We used logistic regression to derive an algorithm, and we got the weights for each of the genes using another statistical method called rich regression. And that then yielded a single algorithm. It had 3 components. The first component was looking at the probability of obstructive disease in males and females. This is what it looked like observed in PREDICT. You can see it looks pretty similar to what other people have shown, essentially a linear relationship for men. PREDICT enrolled patients from age 20 to 90. And in women, a lag in the premenopausal period followed by a catch-up phase. The final algorithm itself is multifactorial. That slide I just showed you is one component of it. There are gene expression surrogates for specific cell type ratios, and I'll take you through what those were. And in addition, there are gene expression changes within a given cell type. And it's all 3 that are involved in the final algorithm. These are the terms and the genes that are in the algorithm. Largely what you see is a role of innate immunity. A lot of genes involved in apoptosis, neutrophil activation, also activation of natural killer cells. There's a significant overlap between men and women, but there are some terms which are unique or differentially weighted between men and women. And I could either spend 2 hours on this slide, but I won't, so we'll just move on. This is a diagram which you have a hard time seeing, I think, with the font color, but essentially it's another illustration of the cell types that are involved. Because when we looked at genes, we didn't base the analysis and the derivation of the algorithm solely on the statistical power, but we also based it on the fact that genes that had a known role in atherosclerosis development or in events were given more weight, especially if they correlated with other genes, which showed better statistical. So once we derived this single algorithm where we're measuring 23 genes in 6 terms, we had locked an independent patient cohort, gotten all the clinical data. We defined case control by QCA. All of that was blinded to all the investigators. And then we, of course, had a predefined analysis plan that our Topol statistical group had. And then we had to run a study, find out, well, would this really work or not? So the first thing I wanted to show you was the comparison is not, is the algorithm significant? The comparison is, does it do better than clinical factors? So this is an ROC analysis comparing, remember, we're looking here at the existence of obstructive coronary disease. We're not looking at predicting events. The best well-validated methodology for doing this was developed a long time ago now by Diamond and Forrester, which uses age, gender, and chest pain type to define risk of obstructive coronary disease. We use that as our primary initial comparator. In this group, the AUC for that was 0.66, and when you add the algorithm to it, it added 6 percentage points, which was statistically significant. Another way to look at this, we've seen a lot of slides that look like this at this meeting too, is to look at reclassification. And what you can see here is actually quite interesting. The red bars are the Diamond-Forrester risk of or presentation of obstructive disease in the patients. And what you can see in the gray bars is that for each of the Diamond-Forrester risk buckets, which are listed along the top, the algorithm score increasing in every group leads to monotonically increasing risk. So if you use the 3-dimensional plot of the bars that we saw in one of the last talks, you would see the same patterns in every case. You can also, I didn't have this on one of my slides, you can also do typical net reclassification improvement analysis. The net reclassification here with respect to Diamond-Forrester is about 20%, and it's statistically significant. So this is what actually the output of the results look like from that overall study. If you look at the percentage of patients with obstructive disease on the y-axis, you look at the score, which we put in for convenience into a 0 to 40 on the x-axis, what you can see is the score goes up. And those dashed lines are the 95% confidence intervals. And the threshold that's shown there is at 20% risk. And about a third of the patients showed less than a 1 in 5 chance of actually having obstructive disease, even though they were already clinically indicated for angiography. So one of the questions was, what are we measuring here? And were we measuring specifically obstructive disease versus non-obstructive disease, or something else? Again, it was our thought that we might in fact be measuring, in fact, disease burden. And here's one way to look at this, which is we bucketed patients as to their maximum percent stenosis by QCA, and we asked them how does the score depend on that, and it turns out the higher your score, the more likely you are to have more disease. We've actually done this a number of different ways now, not just looking at maximum percent stenosis, but other measures of disease burden. One last thing, since I know this is a meeting where people like calcium score, we had a small number of patients in the validation study where they had calcium scores, invasive angiography, and of course CAD scores. What we were able to show was that their calcium score and of course CAD were pretty highly correlated. The R-value is 0.6. In the logistic regression models or ROC models, they're both additive and they're both significant. But in a multivariate logistic regression, at least in this small cohort, and this clearly needs replication, only chorus CAD retains significance. We've got a larger set of patients where we have CAC and the relevant blood samples from PREDICT, though not angiography, and we're looking at those going forward. One last point, the most common imaging modality in this study prior to angiography was myocardial perfusion imaging, which actually really did not perform well at all in this community-based cohort. And what you can see here in our new classification sense is both for MPI positive and MPI negative patients. The higher your chorus CAD score, the more likely you were to have obstructive disease. So to summarize then, and be happy to take questions, we used peripheral blood-based gene expression for the assessment of obstructive coronary disease in non-diabetic patients, developed an algorithm and validated it based on the PREDICT trial. It adds the clinical factors, at least from Diamond Forrester and some other modalities I don't have time to discuss, and it may provide some additional information in non-invasive imaging, although this particular study clearly has referral bias in it. We launched the test in a central laboratory in Palo Alto last year, and we've evaluated more than 3,000 patients with it to date. And I think I'll stop there and take any questions.
Congratulate you for bringing a new vector in all these discussions. But the initial point is that this is symptomatic. These are people who have come to doctor's office because of chest pain, correct?
It's actually in PREDICT, the only inclusion criteria really was no previous known disease, and they were referred for coronary angiography. They're about 80% symptomatic and about 20% asymptomatic high risk.
But asymptomatic because of family history, or
family history, Framingham, variety of factors.
Framingham doesn't nobody goes for angiography because of Framingham.
Non-invasive test results.
Yeah, that's on average something like every patient has had 1.2 non-invasive tests before they went for an angiogram.
I was intrigued by your comment, Mort, that nobody goes for angiogram before a stress test. Is that what you're saying?
Yeah.
In the Medicare database, almost half of the individuals who had a CAD.
No, I said because of Framingham. Just you have a high Framingham.
It's not just Framingham.
You don't go.
Right, I agree. You know, in the Medicare database, about half of the people who go for an angiogram do not have a pre-angiogram stress test.
Right.
And people, about 20% of patients who get a procedure done do not have any evidence of medical therapy initiated before the coronary revascularization procedure. Now, this is true not only for the Medicare database. Eric Topol published it way back in the 90s when he examined a private insurance database. So, what...
They're targeting the same population.
Right.
They're trying to reduce those numbers to go to. I think that's your business model. That's how it is proposed to.
I mean, I think where this could be useful is in a number of cases where patients do not do well with imaging. So obese patients, women, where there's a radiation concern, whether rational or not, especially with the new technologies. It also looks as though in some preliminary work that this sort of analysis is additive to things like stress CCG.
My immediate
I was going to say two questions. One, wonderful work. I did some patients in PREDICT, and I know we did CT angiography. So it might be interesting to get at Mort's earlier question about looking beyond the calcium score, but looking at plaque volume, including remodeling, all that other stuff, to see the correlation with the CT angiograms beyond just the calcium score.
Yeah, we've actually done a little bit of that with Solar Boros in the Atlanta study, where some data that was presented in a poster at HEVB, we've done some looking at more extensively at virtual histology and other markers, and it does seem to correlate plaque volume from CTA, and actually in a very small study also in IVUS with plaque
Even
volume.
I didn't PREDICT. We did some CTAs in PREDICT
Yes.
for a while. So I was one of the investigators, and I was enrolling patients with CTA as well as with cardiac cath for a while. So we have some.
Those were some of your patients there.
Might be some,
I'm sure.
but the other question I had was pre-test versus post-test probability. You showed post-test probability, but not based. I didn't see it based on pre-test probability of obstructive disease. Maybe I missed that.
So remember, since we needed to have a gold standard, we can argue whether the gold standard is tarnished or not. But we needed the gold standard, so everyone's referred for angiography.
Right.
So if we were perfect, we would say the pretest probability should have been 100%, and we had no need for another test, right? But we can calculate pretest based on the population comparing to force. And then, in fact, what was the ROC curve?
Right.
There is
But showing individual calibration based on pre-test to post-test, you might be able to find a specific niche where the pre-test probability for cardiac cath is below 70%, where your test has even higher discrimination.
Yeah, no, I think that's right. And if you look at the reclassification data in detail, we can look at all the numbers if you want. I have a backup slide, but yeah.
Yeah, so when we raised this question in shape before you actually were invited to this meeting, one immediate question was, there's no way genetic tests that could be predicting or useful in doctors. So you made one clear slide. This is not a genetic test. This is a gene expression test. And when I look at your findings, it just strikes me that this might be just a post-operation phenomenon, meaning what you're measuring in these mRNA are the result of what happened after an obstruction. Could be because apoptotic genes and neutrophil activations are all things that could happen because of minor infarct, minor ischemia, and activation of neutrophils, and you're measuring it. How do you distinguish this, that these people actually might have had something downstream to that plaque that you're measuring?
So, I mean, we did exclude anyone with elevated enzymes, et cetera, from the study. So they didn't have any acute symptoms. Whether they had some asymptomatic MI sometime previous plaque rupture that you couldn't see, I mean, it's possible. I can't rule that out.
Sanjay?
Yeah, are you capturing clinical outcome
Data, I know it's only about a year plus follow-up, but I'm sure that some clinical outcome events may have accrued in your data set.
Yeah, at 1 year, which we've gotten about 90% now, we've got 3% events.
So 3% of 3,000 would be?
Well, it's 3% of 526 in the validation cohort, so it's only 15.
Okay, so not sufficient enough to make any?
We look at it every day, hoping for, but actually there's some retrospective cohorts. We've gone back to CathGen, where there are more events, and we're always looking if anyone has PAX-gene tubes squirreled away and has follow-up with events, we'd love to talk.
See, the reason why I asked that question is that I have a difficult time believing that a portfolio of gene expression studies that target local pathobiology may have similar or better predictive performance in outcome events. I think that's just, what are we studying here? Are we studying the integrated impact of systemic factors on plaque, or are we studying some local pathobiology of the plaque?
Let me go back to one slide because I think it's relevant to that point. So the more disease you have, the higher your score. We know the more disease you have, the more likely you are to have events globally. I'm not going to get into whether they're obstructive, non-obstructive, what kind of plaque. So we believe with no data, and that's why, that the score should be prognostic, but it hasn't been shown, so you can't claim that. This study was done the way it was done because you get your endpoint the same day you get your blood sample. What's the result of the angiogram? And that's where we started. To do the prognostic study right, we're actually talking with a number of major cohorts to be involved with running in a truly prospective manner the gene expression test, putting the data away, waiting the 3 to 5 years. We can't afford to do that ourselves, but in collaboration with others, we think it might be possible.
Were these cells monocytes or what it is?
No, it's whole blood. It's actually a whole blood sample in a packaging tube. And then we isolate whole blood RNA. We actually developed a very nice automated way to do that on a robot to make things more reproducible and efficient.
You don't anticipate these reflecting anything in RBC?
No, none of the genes are not expressed. I mean, you could, but anytime you process cells, you start changing things. So you want to minimize processing as much as possible.
We have lymphocyte cell line.
Oh yeah, they're very tweaky. Yeah.
I still have a feeling that this must be somewhat related to something associated with something downstream. It's not enough to trigger enzymes, but it means enough to, or something before a few days before the event. Because 80% are symptomatic. Symptoms doesn't come out because of nothing, but because of...
Oh, but most of the symptoms are, stable anginal symptoms or atypical symptoms. There are a lot of people who have symptoms that really aren't important.
We know from literature, we know that ischemia, cause neutrophil activation is associated, ischemia is associated with apoptosis, and if they're all circulating, you'll be able to detect it. So either way, you have a detecting tool.
Yeah.
We're going to have to see the cost effectiveness. Dan, you have
Yeah, it just seems to me you're correlating it nicely with disease burden. This might be stable anatomic disease. I'm wondering, and it would appear that this gene expression might be something that's related to a changing, to a dynamic, to an unstable phase or an active phase of the disease. So have you looked at the difference between patients who have more acute symptoms rather than those with just chronic stable symptoms?
Early on, when we were just starting this, we actually had a much more heterogeneous clinical phenotype in the patients. And then as we honed in on sort of what was the clinical decision we wanted to focus on, we focused on this one. Should you take something to the cath lab or not? The early data suggested that, in fact, exactly what you're saying, that the signature is more extreme in unstable patients. But it was early, and there were lots of reasons why I would want to redo it. But it's a good point.
Because I can imagine that with the imaging approach that we might be coming up with, we could have levels of disease that go all the way up to high. But if the high levels of disease are associated with little activity, maybe that will affect clinical management.
Yeah, no, I mean, it's my belief that these expression changes we're seeing in the white cells is a composite of disease activity plus disease burden, and some function of the two of them together. That seems like the logical.
And or treatment.
Yeah.
I mean, I still can't get by on the gold standard here.
Right.
It's a premise. And geography, I just can't.
I think Dan had a very good point. We have a lot of methods of measuring disease structure in anatomy, but we don't have any activity measuring. This works.
This might.
CRP tried to do this and saying that CRP has an
Right, CRP in this study has no significance in saying who has obstructive disease and who doesn't.
What?
It might be a mark of endothelial dysfunction function, endothelial activation, because we know there's interaction between leukocytes and endothelial.
But their markers are more than, they have apoptosis, they have neutrophil activation, they have some other things which is.
But no, you can't rule out that, we're not looking at some information processed signal through the endothelium. I mean, I think there's a lot of potential interest in, endothelial progenitors potentially and other cell types which might be of interest.
Thank you.
If you want to look at the activity of the disease, it might be much more useful to do this test in patients who are going for CAS with stable angina versus unstable angina. Don't you think you will then be able to clearly know if this test actually focuses not only on disease burden, but more so on the activity?
I guess the question, it takes a couple of days to run this test from when you pull a sample. It's not like you could do it in the emergency room immediately. And so, but as a scientific question, you're absolutely right. As a wearing my company hat, I'll sit there and say, well, yeah, but what am I going to do different as a clinician if I get a result? If I already know they're unstable.
Well, I think the answer to that is that if you study it this way, and you find that those who are unstable have much higher levels than those who weren't, then people in the stable phase are going to listen more to the results in terms of how they're going to manage people, and they're going to say, I want to measure this test because it's going to give me an idea as to whether this patient has active disease or not.
You think that would be better than measuring events and prognosis?
I would argument the other way around. The pathology has shown, and we know it from pathology has shown, and we know it from endovascular ultrasound, we know it from OCT, we know from angioscopy, that roughly 20% of those who are characterized as stable are unstable. They have disease, and they have plaque rupture, and they have thrombus formation, despite the fact that they are judged clinically as stable. And when you look to sudden death and on the paper of Davis, and I think also Erland published it, you see that those who have sudden death and were stable or unstable, they only differ in the amount of disease which was present when they looked for it in the convalescent history. So it would be nice, of course, to have a better discrimination of those who we judge as stable, who are from the pathological point of view are not stable.
Good point. So we're going to move over the section that we had previously planned for. That was expensive and interventional therapies, their potential for asymptomatic population. So if you find somebody with non-invasive modality like CTA with a very high-risk plaque or thick fall or thin fibrous cat, would you ever in future consider an interventional approach? So we invited Roxana to present that.